Once the pt2.avi implant is stable, the plastic carrier is replaced by the finger key, matching the hexagon of the implant diameter. Slow insertion with apical pressure allows for improved vascularization of the osteotomy while utilizing the self-tapping feature of the implant. To ensure a progressive expansion of the osteotomy, the implant is rotated counterclockwise and then clockwise again until the implant is completely inserted into the osteotomy. As demonstrated in this video, the bone will adapt to the implant under slight but gradual increased pressure. The final positioning occurs within the last 2 thread rotations at lightly increased pressure, and final anchoring of the implant can be easily felt. It is recommended to rinse the internal hexagon with sterile irrigation to remove possible debris. The cover screw is then removed from the plastic cap and inserted into the implant using a 1.7 mm hex key and hand tightened. The flap is sutured using a 4/0 vicryl suture using an uninterrupted mattress suture, and the healing begins. The post-operative radiograph demonstrates that the implants have been seated in the proper position relative to each other and the adjacent teeth, as well as the osseous crest. This patient is a 20-year-old male who has a missing maxillary right first premolar tooth number 4. The panoramic radiograph shows an adequate vertical dimension of bone for placement of a 10 mm pt2.avi implant. A study cast was fabricated and the diagnostic wax-up was used to create the surgical template. A mucoperiosteal flap was planned to gain access to the crestal bone. The initial incision includes a sulcular incision around tooth number 3 as well as tooth number 5, using a microsurgical blade. A crestal incision is made to allow access via a full-thickness reflection. The periosteal elevator is used for the elevation of the flap. The surgical template is applied to the site, and the position of the osteotomy is initiated with the initial perforation drill, or IP drill, using copious irrigation and the drill speed of 1,000 RPM. The orientation of the osteotomy is made relative to the surgical template. The next step in the osteotomy preparation is the 2 mm twist drill, which is extended to the full depth of 10 mm for the placement of a 4.0 by 10 mm pt2.avi implant. Once the osteotomy preparation is initiated with the 2 mm twist drill, the initial osteotomy depth can be verified with the depth gauge. The depth gauge has length graduation starting at 8 mm and continues in 2 mm increments. At this time, the thinner 2 mm half of the paralleling pin is placed into the osteotomy to determine the alignment with adjacent teeth, and proper occlusion is verified at this stage. A radiograph is recommended at this step. The coronal aspect of the osteotomy is now widened from 2 mm to 3 mm with the 2 caliber drill at a drill speed of 1,000 RPM. The widening of the coronal aspect of the osteotomy allows adequate access for the following final precision drills. Since we are placing a pt2.avi implant of 4.0 mm diameter and 10 mm in length, we continue widening the osteotomy with the 3.25 mm final precision drill color-coded with a green ring to the full depth of 10 mm. The bone quality in this case is identified as D3, Therefore, the following 3.75 millimeter final precision drill is inserted to only 2/3 of the full depth. The final drilling sequence with the 4.0 millimeter final precision drill, color-coded in red, requires a preparation of 1/3 of the depth of the osteotomy due to the soft bone quality. Throughout the osteotomy preparation, copious irrigation is applied in conjunction with relatively slow speed of 1,000 RPM to ensure gentle preparation and minimal thermal injury to the osseous structure. It is recommended to flush the prepared osteotomy site of all bone debris with copious sterile irrigation. As the site refills with blood, the implant is removed from its color-coded sterile vial and transported to the site with its carrier. As the pt2.avi implant moistens with blood, the proper insertion angulation is confirmed and the implant is inserted with clockwise rotations using the plastic carrier and finger pressure. Once the pt2.avi implant is stable, the plastic carrier is replaced by the finger key matching the hexagon of the implant diameter. Gradual insertion with apical pressure allows improved vascularization of the osteotomy, while utilizing the self-tapping feature of the implant. The bone will adapt to the implant under slight but gradual increased pressure. The final positioning occurs within the last 2 thread rotations at lightly increased pressure, and final anchoring of the implant can be easily felt. It is recommended to rinse the internal hexagon with sterile irrigation. The cover screw is removed from the plastic cap and inserted into the implant using a 1.7 millimeter hex key and is hand tightened. The flap is sutured using a 4/0 vicryl suture using an uninterrupted mattress suture, and the healing begins. This patient is a 20-year-old male with a congenitally missing maxillary left cuspid and retained mobile primary tooth in its place. The patient desires immediate implant placement and temporization in the aesthetic zone. The periapical X-ray shows a congenitally missing maxillary left cuspid and the retained primary tooth. A study cast was fabricated and the diagnostic wax-up was used to create the surgical template. A minimally invasive extraction technique was initiated by severing the gingival fibers in a gentle manner to facilitate the extraction of the tooth.